The illusion of stability in heart failure is a big issue. 20% of stable patients, like the patients who never had a heart failure hospitalization in PARADIGM trial, had a primary event. In fact, 17% of them died during the course of the trial. Of stable patients who experienced a primary event, death preceded heart failure hospitalization in around 50% of patients. In fact, the 60% of these deaths was sudden deaths, sudden cardiac deaths. So ARNI should be started as early as possible. Do not wait till the patient deteriorates, because he can have a sudden cardiac death also. There's a 2022 ACC AHA consensus guideline, which recommends ARNI as a first-line treatment, class 1A recommendation for HFrEF patient with NYHA class 2 to 3 symptoms to reduce the morbidity and mortality. But if the patients with the previous or current symptoms of HFrEF, the use of ACE inhibitor is beneficial to reduce the morbidity and mortality when the use of ARNI is not feasible. But generally, that is not the case. ARNI generally is feasible. And if it is not feasible at all because of the cost or any other issues, then ACE inhibitors can be used. If patients who are intolerant to ACE inhibitor because of cough or angioedema, then and when the use of ARNI is not feasible, then the ARBs can be used. And in patients with previous or current symptoms of chronic heart failure with reduced infection, if ARNI is not feasible, treatment with an ACE inhibitor or ARB can have some economic benefit for the patient. So if not possible, then only use an ACE inhibitor on ARNI, ACE inhibitor or ARB. Otherwise, ARNI is the first drug of choice. In acute decompensated heart failure, different from de novo heart failure. De novo heart failure is a distinctive phenotype from acute decompensated heart failure. Like if you compare a decompensated heart failure patient, they generally have an older population, worse baseline status, laboratory findings are abnormal, and known history of heart failure is there. Unlike de novo heart failure, which there is no history of heart failure. There are a lot of comorbidities, right from obesity to AF to diabetes to COPD, stroke, post-bypass, post-angioplasty in acute decompensated heart failure, unlike de novo where there is no such history. Trigger events can be medication non-compliance, infections, diet, cardiovascular complications or interventions, drugs. But in de novo heart failure, cardiac ischemia or valvular incompetence like acute MI or acute mitral regurgitation, inflammation or toxic drug-induced results generally are there. Now, clinical presentation is dyspnea, orthopnea, lower limb edema, ascites, weight gain in cases of acute decompensated heart failure, and more like a cardiogenic shock and acute pulmonary edema, more rapid and dangerous kind of sudden presentation in de novo heart failure. And the main pathophysiology for acute decompensated heart failure is pulmonary and systemic vascular congestion caused by LV dysfunction, maladaptive neurohormonal activation, fluid overload, and redistribution. Unlike acute hemodynamic derangement caused by LV systolic dysfunction like an MI in de novo heart failure. So these two are different subsets.